welcome to everyone and thanks very much for joining us. This webinar draws on Resist research findings to answer the question, can improved tax collection systems boost public funding for health? We will start with an introduction to Resist and the research from Professor Di McIntyre, who's based at the Health Economics Unit at the University of Cape Town. And she'll be followed by a presentation from Dr. Jane Doherty, who's affiliated with the School of Public Health at the University of the Witwatersrand. There'll be a question and answer session at the end, so please type your questions into the box at any time and we will make sure that they get addressed at the end. Thank you, and I'll pass on to you, Di.
Great, thank you very much, Becky. Welcome also from me, and thank you very much for making time to join us today. I just wanted to start by saying a few words about Resist. And Resist is really, it's a research consortium, an international research consortium, focusing on how to enhance resilient and responsive health systems, with a particular emphasis on how to promote health equity. It includes 10 institutions in Africa and Asia, along with the London School of Hygiene and Tropical Medicine. Now, one of the key themes is healthcare financing, and especially issues around how to ensure that there's adequate financing for universal health coverage. Some of the research that has been undertaken under the financing theme has focused on generating revenue for health services, and what the results being presented today come from that area of research. But I just also wanted to mention that there's a very large research project which involves all of the Resist countries, which has been focusing on how to effectively purchase health services with the available funds. So I would encourage everyone to have a look on the Resist website and see some of the findings that are coming around about purchasing health services. So as Becky mentioned, today we're going to look at the potential to increase tax funding, particularly in the context of not necessarily increasing tax rates. Very often we hear that it's not feasible for governments to increase spending on health services or other social services because there isn't fiscal space. So today we want to just have a look at that, and particularly to look at the cases of South Africa, Kenya and the Lagos state in Nigeria, where it has been possible to actually increase tax funding. As Becky mentioned, Dr. Jane Doherty will do an initial presentation. She led the study in South Africa and also led the cross-country comparative analyses. So she's going to do the presentation on behalf of all of the countries, but we're very pleased to have members of the research teams from Kenya and from Nigeria with us. Doris Karigia from Kenya. I don't see Hyacinth Ichoku online at the moment, but I do see Chijoki Okoli, who was involved in the research from the Nigerian perspective. So we'll have the presentation, and all three countries, South Africa, Kenya and Nigeria, will be available to answer any questions you might have and to engage in discussion after the presentation. So I'm going to hand directly over to Jane Doherty to run through the presentation. As Becky mentioned, please do type in questions that you may have into the chat box, and we look forward to the discussion after Jane's presentation. Jane, over to you.
Thank you, Di. Hi, everyone. Just to make the point that the authors of this presentation come from all three countries, but there are additional researchers who participated, and we do acknowledge them at the end. So quickly, just the structure of the presentation, which I think should take about 20 minutes. I'm going to spend a moment talking about this term fiscal space, which we often throw around as a kind of shorthand for talking about whether there's enough money for government spending. Then a brief slide on methods, It's been quite a big project, so I'm not going to spend too much on the methods. I'm trying to keep time open for the actual findings. Then you'll see that there are, on your screen, there are 4 headings in green. These were essentially the research objectives for the study. And so I'm going to present the findings according to those. The first one was, how did the case study countries achieve improved tax collection? I present some of the explanatory factors for their success, but I also thought it relevant to note some of the future challenges, because some of the lessons from these countries really come from a period when the economic and political climate was somewhat better than it is today. Then I'm going to go on to talk about, with the improved money the government managed to collect, how did it allocate that money to different sectors, and which sectors came out top in that sort of game for resources. I'll focus first on what happened to the health sector, and then look briefly at what happened to other sectors which were competing for resources against health. Next, I'll go on to look at what explains the public health sector's position in this race for more resources, and I think that's really the critical part of our analysis to understand why these trends emerged. I'll conclude briefly with the main findings, and then the last slide is about what countries can do looking forward to try to improve their fiscal space for health. So firstly, this definition of fiscal space comes from one of the RESIST briefing documents. It says that fiscal space for health refers to the capacity of government to provide additional resources for health without jeopardizing its long-term financial position and economic stability. And what we've done in the study is look at whether fiscal space for health has improved, essentially within a context where the fiscal space for government as a whole was fairly healthy. So we've mentioned already that there were 3 countries involved in this case study series. They were chosen for particular reasons. They first of all represented a range of countries in terms of GDP per capita. So Kenya was at that time classified as a low-income country. The Lagos state in Nigeria as a lower middle-income territory, and South Africa as an upper middle-income country. Kenya at that time was a centralized political and administrative system that no longer is, but our data comes from that era when it was still centralized. Whereas Nigeria and South Africa are both quasi-federal systems. This means that part of the responsibility for healthcare has been devolved to both the Lagos state and to the provinces within South Africa, whilst the central national government has retained some responsibility for healthcare. Thirdly, all 3 countries in the last 15 to 20 years had undergone quite dramatic political change towards improved democracy, and this had ushered in a period of, I suppose, enthusiasm and commitment to improving social services and equity, especially in South Africa and Kenya, maybe less so in Lagos state. And all of the countries had seen over this period a 2- to 3-fold improvement in the size of the government budget through improved tax collection, but without increasing tax rates for individuals or for companies. So in fact, in all 3 countries, these rates had declined, but revenue collection had improved. Our approach was to use mixed methods. We got together frequently and developed a common research framework. We used 2 theoretical models for the different parts of our study, one looking at understanding the capacity of each country to generate tax, and another to understand, with respect to the allocation of the government budget to different countries, we use a policy analysis framework. So you can look at more background on these 2 frameworks on the products that appear already on the RESIST website. We collected data from documents. We looked at revenue collection and expenditure data from national accounts in each country, and we did a series of interviews across all 3 countries, I think about 35 in total. Then in terms of data analysis, we used a thematic content analysis approach for the qualitative data and trend analyses for the quantitative data. Now, there are some limitations in our study, as in all studies. All the countries experienced difficulty accessing senior officials for interviews. We were interviewing people at a very high level, and they were often busy, and sometimes it proved impossible to reach them. Lagos State in particular had quite difficult quantitative data to analyze. This is a state that recently became, or in the last decade or so, began setting up its own regional government. And as a consequence, a lot of the categories for the data are not quite as consistent as we experienced in South Africa and Kenya. And I'll come back to that a bit later. And I'm sure the Nigerian researchers will refer to that if there are questions. So let's look at the first question. How did the case study countries manage to achieve the improved tax collection that we have witnessed in the last 15 or 20 years? So I'm going to go through a number of explanatory factors quite quickly. I think the main interest for most of you is looking at how the budgets were allocated to health or were not allocated to health. So this section, which really focuses on the tax collection strategy of each country, will be fairly brief. So first of all three countries had external environments around the tax collection system that made it easier to collect taxes. So firstly, all three governments had increased legitimacy following these political upheavals that had ushered in greater democracy. And they were lucky, all three countries, that this sort of improvement in democratic institutions and processes came along at the same time as fairly strong economic growth, although I shouldn't overstate the case. In all three countries there were ups and downs in the economic fortunes of each system. Secondly, all three countries had favorable public sector institutional environments. So around the main group, the tax collection agency, was a public sector that was functioning well and in sync with the objectives of the tax collection agency. So firstly, there was very strong political support at the level of cabinet, the president and the Minister of Finance, very, very strong support for the tax collection process and project and for the tax collection agency itself. Secondly, tax policy reforms were ushered in that made it easier for the tax collection agency to reach a wider tax base. And especially Nigeria might like to speak a bit later about how Lagos State managed to reach the informal sector, a sector that's traditionally very difficult to raise taxes from. Thirdly, I think this is really important and unusual for many countries in Africa, the tax collection agency in all three countries managed to somewhat delink itself from the public service administration without leaving the public sector. So all three countries had semi-autonomous agencies that could hire and fire and could develop their own strategies and had the freedom to make short-term and long-term decisions, but still remained accountable to their political heads, the Minister of Finance, and through them to Parliament. And lastly, all three countries had very strong and sustained leadership in their agencies. In South Africa, for example, our current Minister of Health remained the head of the tax collection agency for as long as 10 years and then moved on to become Minister of Finance. And this provided a continuity that was really important to drive through what were massive tax reforms. The next point speaks to the fact that all countries were very good at linking their tax agency with a number of external sources of assistance. All used consultants, both country consultants and international consultants, and they used them very wisely. So they brought them in and embedded them in their organizations so that the consultants themselves were guided by national priorities. And also trained local people in the process. And then they also built longer-term arrangements with banks and other government departments, which allowed them to link through quite complex IT systems into all kinds of other sources of data, which allowed them to track the tax returns of clients and validate them. Then the tax collection agency in each country was the attention of enormous attention and resources, and in all cases was transformed, both in terms of its organizational structure, but also in the kind of culture that was used to really, I suppose, enliven what had been quite bureaucratic organizations. So all of these countries saw tax collection agencies that no longer look like the conventional public sector institution. They're very dynamic, very efficient, and very proactive. Then in terms of collecting tax, these countries all decided not to try to collect from everybody all the time, but prioritized high-risk and low-risk groups and targeted the efforts on the high-yield and high-risk customers. They all used multiple strategies for cajoling taxpayers to become compliant. So they use sticks and carrots of various sorts, often quite creatively, including public campaigns that made it really fashionable for people to pay tax, because by doing so they were contributing to social objectives. And then lastly, all of them when tax compliance wasn't good, they managed to employ a range of enforcement strategies that either audited people and identified incorrect returns, or at the other extreme jailed them for tax avoidance. And then lastly, and very importantly, all countries had a very concerted human resource development capacity within the tax collection agency. They improved the numbers of people working there. They improved retention so that they got skilled staff staying longer. They redeployed people according to their skills, which often is not the case in a bureaucratic institution in government. And they employed a number of positive and negative incentives to ensure that their staff were efficient and honest. So I can give an example from South Africa, where the whole issue of honesty became a very upfront value of the organization, and people who were found to be corrupt within the organization were heavily penalized. So that concludes the section on explaining why they were able in the end to increase tax by twofold in the case of Kenya and South Africa, and threefold in the case of Lagos State. So these strategies really had an amazing effect over a period of 15 years. But the people we interviewed all cautioned against saying that this sort of easy ride would continue. They pointed to the fact that the globalization of trade and the surgence of e-commerce has really posed a number of almost insurmountable problems to many of the tax collection agencies. It's very difficult to track and capture tax when you've got a globalized system. There's also, as we know, changes in all these countries in terms of the political systems and the level of support that the populace gives to governments. And that's an unpredictable factor in all three countries. Economic instability was ushered in 2008 in particular. I'll come back to this issue of fiscal policy. It'll become a bit clearer at this point when I talk later on to the reasons behind why health did or didn't get the allocations it did. I'll come back to that point, so just hold on to it in your mind, but it's a very important point. So the point really is that the fiscal policy in each country can turn and change, and therefore have a big impact on the chances of the health sector. The informal economy still remains a problem in all three countries. And lastly, public perceptions are 10 or 15 years ago, there was much more confidence in the role of these three country governments. And there's much more instability currently, at least in South Africa. All right, let's turn to which sectors benefited from improved fiscal space. So we know that there was improved fiscal space. Which sectors enjoyed funding from this sort of boon of increased money in the 1990s and early 2000s? So I'm going to show you now a series of graphs, one for each country. I'll explain the first one in more detail so you understand how the graph is structured. On the left-hand vertical axis, you see the figure is for the currency of the country, and it relates to the grey line on your graph and to the black line on your graph. And the vertical line on the right-hand side relates to a percentage, and that is connected to the dotted line. So this graph for Kenya shows that total government expenditure rose rapidly between 1998 and 2012. And you can see here that health expenditure didn't rise in proportion. You can see that quite clearly. And then you can see too that if you look at health as a percentage of total expenditure, the percentage gradually declined over that period. This is the same slide for Lagos State, and you can see a very similar pattern. Dramatically increasing government revenue, health expenditure that only increases mildly, and a slowly declining percentage for health as a percentage of the total government expenditure for health. And a similar pattern for South Africa. The difference here is that South Africa, in terms of as a percentage, health enjoys a lot more of the budget than Kenya or Lagos, but essentially a similar pattern. And in South Africa, what's slightly different is that you can see quite a marked dip in the early years post-apartheid, and then a recovery slightly later on. Now, another way of looking at what happened to health spending is to look at health spending per capita and compare it to GDP per capita. This essentially asks the question on the slide, did health benefit from the increased wealth of the country as a whole? And you can see in Kenya that while at the beginning there was a dip in health spending per capita, the grey line, it in subsequent years managed to climb up and has been increasing at a similar rate to the increase in GDP per capita. But let's look now at the situation in South Africa. You can see a different pattern here. Again, we see that per capita expenditure declined for about 10 years after apartheid, and only after 10 years began to rise again, but hasn't reached the levels, or hadn't reached the levels after about 15 years that it had in 1994. You can't see that on the graph. 1994 was when apartheid came to an end. So a surprising finding here, because health policy in South Africa was one of the main policies put forward on his election platform by President Mandela. So if health didn't do that well, what happened to other sectors? Now, we didn't look at all the sectors. We chose some of the major social services and some of the major sectors in each country to look at. And you can see here that in Kenya, health wasn't alone in experiencing a decline. Education also declined. And you can see a category called public admin and international relations, which also declined. But the sector that seemed to benefit a lot here in this period was that of governance, justice, law and order, and also energy, infrastructure and IT. So the issue here you can see in Kenya was a reprioritization, it seems, of resources towards governance and law and towards energy and infrastructure and IT for economic development. Let's look at the case in South Africa. So in South Africa you can see too that education declined along with health. And the sectors that seem to have gained by this decline was social protection. In South Africa, there's a big social grant system. And the other one, the third line on the right from the top, is economic affairs. So here in this country, a prioritization of creating a safety net for the poor, essentially, as well as trying to develop business and economic activity. I don't have a slide here for Lagos because we had difficulty with the data for Lagos, and also very volatile data that made the graphs difficult to read. So let's go on to the next question, which is what explains the public health sector's position in this race for more resources? Why on earth did health decline when it was a priority, at least in Kenya and South Africa? So the answer really is that there's a complex interplay that we found in all three countries of economic, political and administrative factors. So firstly, let's return to this issue of fiscal policies. As I've mentioned already in the previous graphs, we've seen that there might not have been a conscious prioritization of other sectors, but de facto, in practice, there was a prioritization of sectors such as economic growth, which was obviously a strong policy in South Africa and also in Nigeria, I think. A macroeconomic policy that favored the idea of economic growth through promoting productive sectors and by providing infrastructure, and then law and order in the case of Kenya and some of the other countries too. Very importantly though, and maybe more importantly, and certainly in the case of South Africa, there was, despite attempts to improve the collection of tax, there was a ceiling on the amount of tax that could be collected. And this was in the form of a tax to GDP ratio of 25%. So the macroeconomic policy stated that tax should not rise above this, in South Africa at least. And as I'll show later, this has been a big reason why there hasn't been more money in the government budget and not enough money for health. Just to give you a comparison, that figure of 25% is much lower than the average for Latin America and other middle-income countries. It's about 32% there and about 37% in Central and Eastern Europe, and about 34% in high-income countries. So a very low tax-to-GDP ratio in South Africa. Thirdly, in the case of South Africa too, there was an attempt to rapidly service government debt post-apartheid, and I didn't show this on the graph, but that took a slice off the total government budget, which is partly responsible for the decline in health spending in South Africa at that time. All three countries, though, did shift some of their spending towards what we would call the social determinants of health, so things like social social protection, things like water, housing, all of those countries were clearly trying to boost spending on those sorts of services, which could be argued to improve health as well. And lastly, there does seem to have been some substitution for government health spending by donor funding. So in the case of Kenya, for example, neither South Africa nor Lagos State receive donor funding. So in Kenya, there is additional funding that I don't show on the graphs that comes from donors. But as we know, donor funding is not reliable and sustainable over time. So this short-term substitution, in fact, creates some volatility in the fiscal space for health. Another set of causes seem to be the decentralization of political and administrative systems. This is an unintended consequence, I think. So certainly in Lagos State, the cost of setting up a decentralized government seems to have captured a huge proportion of the government budget, which squeezed out the social services and sectors. Secondly, all three countries seem to have had difficulty ensuring equitable allocations around, so geographically around their country because of the complexity of managing decision-making around resource allocation in a decentralized system. And thirdly, all three countries clearly have difficulty tracking expenditure when it comes from various sources, which makes it harder again to monitor the size and the equity of health allocations. And thirdly, just generally at a national level, I think in all countries, the budget negotiation process is quite complex and quite opaque. It's difficult to sustain arguments for health once the initial bids by health for a budget has gone into the deep negotiation process. And most of the countries mentioned that there's very little technical capacity at that stage represented, or health technical capacity from the health departments represented at those stages to keep up the arguments in favor of health. Very interestingly too, the personal attributes of the Minister of Health also seem to be a deciding factor. In the South African case, for example, there were some very strong ministers of health who seemed to be quite successful in arguing for increased allocations to health, extremely successful. But there was who somehow seemed to lose the support of her cabinet ministers, her fellow cabinet ministers. She also lost support, popular support, and it was during her time that in fact there was quite a steep decline in allocations to health. Very importantly in all countries, and I think this might be obvious to everyone, that the Treasury has a big influence on how much money is allocated to the health sector. And clearly they sometimes have different priorities, internal priorities for economic growth than Cabinet as a whole, and they're powerful members of Cabinet, the Ministers of Health, and they, in these three countries, seem to have swayed the allocations towards their vision for economic growth and financial sustainability. Clearly, in all three countries, they also often are skeptical of the ability of the Ministry of Health to absorb funding and to use it efficiently. And I think this is a key finding of ours, and I'm going to quote one of the Nigerian interviewees. The Minister of Health has weak absorptive capacity, so even with the allocated budget, you will find that the Ministry of Health is one of the sectors that will return funding due to underutilization. This could be due to internal politics within the ministry or delayed projects approvals. This is a ministry that has many challenges when it comes to timely budget utilization, but they always argue that funds given to health are insufficient. The next point equally important is that ministries of health themselves do not seem to have the technical capacity or the, I suppose, strategic ability to mount and defend strong bids against other sectors. And they also have problems in demonstrating the impacts of their health programs, so they find it difficult to provide evidence when they are effective and efficient. They have difficulty providing the evidence because of the difficulty of measuring health outcomes and relating health outcomes to very complex and widespread interventions. I'm not going to read that quote, but it's about the problems around trying to use expenditure information to prove performance improvements in health. And the last point here in terms of understanding why health has not gained greater fiscal space over the last 15 years in these three countries is that there don't seem to be strong parliamentary and civil society campaigns that support the notion of health as a human right, of health as a way to build strong human capital, of health as a way to build cohesive societies. except perhaps in South Africa at one stage you might know of a very successful campaign motivating for HIV treatment. But apart from that, there hasn't been really a strong agenda for health in any of the three countries in civil society. So let me come to the conclusions now. So these case studies show that it is possible to increase domestic revenue even in low and middle income countries and even in a situation with lower tax rates than the norm. That this doesn't create improved fiscal space for increased government expenditure overall. But despite this, and despite the considerable health and healthcare problems experienced by these countries, health wasn't able to capture part of this fiscal space successfully. In fact, none of the countries was able to increase its share of fiscal space, and all of them saw a decline at certain stages over the 15 years we studied. So this complex interplay between political, economic, and administrative explanatory factors explains this, even in a country like South Africa, where health policy was and remains very high on the political agenda. So a sort of a unexpected finding this, and something that's quite difficult to unpack. So taking this knowledge, how can we advise ministries of health who want to influence resource allocation decision making in their favor? So certainly ministers of health need to very actively engage cabinet and treasury around appropriate fiscal policy choices. And this is not something that normally I think ministers of health think they have to do. But I think from our presentation we've shown that the problem with allocations to health starts way back in decisions around how to tax, who to tax, what levels to tax, and how to spend tax money to achieve a society where there is human well-being. So how could health use the influence to try to change the debate in cabinet? So we thought that one way would be to make the trade-offs explicit between going for conventional economic growth strategies versus going for social development. So to make those debates, have them quite robustly, and to highlight the human rights, human well-being, and equity issues within those debates. And then secondly, to use these debates to persuade the cabinet that investing in health is a productive choice. It's not about spending money unproductively. It's about creating a population that is healthy, that can work, and that is socially cohesive. The second issue is for health to develop much stronger capacity within its ranks to mount and defend strong bids for additional resources. And this sort of capacity is of two sorts. It's partly a technical capacity to do the economic analyses, to do analyses of expenditure and performance, etc. But also it's a capacity to be present in the negotiation process, way into the process, to protect arguments for health spending. Then, of course, health should improve the efficiency of its services to allay the fears of Treasury and at the same time document its successes and demonstrate the debilitating effects of underfunding. So underfunding itself can bring inefficiency. And lastly, develop clear advocacy strategies with the support of civil society. There's just a slide here acknowledging the funders and the other researchers and the interviewees in the project. Thank you, Becky.
Great, thank you very much, Jane. I wanted to check, Doris, is there anything you'd like to add specifically from the Kenyan perspective?
Thank you very much, Jane and Di. I think the presentation has been inclusive. The only thing I can mention is that Kenya particularly managed to increase the taxes collected by also trying to bring in the informal sector, and this they actually introduced a micro and small enterprise sector that was able to contribute to the taxation process. Thank you.
Great, thanks very much, Doris. As I say, unfortunately our Nigerian colleagues are not with us because I think the issue of the informal sector and how to draw the informal sector into the tax net is quite difficult, and I see that there's a question that's just come in about lessons about collecting revenues from the informal sector. So I'll just try to say a few things about the Nigerian experience, because there's two ways in which one can go. The one way is to focus a bit more on some of the indirect taxes, because that would tend to capture people working in the informal sector, and some of the what they call innovative financing mechanisms. So, for example, introducing a special levy on cell phones. You know, it tends to be that people who have more resources will use cell phones more, and what we find increasingly in Africa is that a lot of people working in the informal sector use their cell phones quite a lot, either as a form of getting payments in, etc. So that could be one mechanism through sort of indirect means. But in Lagos, certainly, they actually tried to get the informal sector to start paying some form of income tax. And the way that they did that was really through working through the informal sector associations. So associations of street vendors or other associations of informal sector workers, and employing more people from the tax office side to go and work in the field to establish relationships with informal sector organizations and try to draw them in that way. So that's just a little bit on the informal sector. So I can see that there's a whole string of questions that have come in. Jane, I don't know if you'd like to add anything on the Nigerian experience with the informal sector.
No, I think you've covered that, Di. Maybe just to say that in effect what they did is that they took informal trade associations and transformed them into a tax base. And what I would have liked to know more about from Nigeria is how they managed to convince people to participate. You have mentioned already that they employed women in the tax agency who came from similar backgrounds, I think, to promote dialogue with women's associations. So that must have been one of the mechanisms. But there must have been other incentives, I presume.
I wanted to pose a question to participants. One of the things that it really was very striking that we saw very dramatic increases in tax revenue in these three examples, but in all three examples the health sector didn't really benefit from those increases. And we've seen, certainly in terms of the Abuja target, where there's been pressure for the health sector, to push for African governments to put up to 15% of the government budget into the health sector, and it really hasn't happened in many countries. So in this study we came up with some of the things that were barriers, but I would be interested in hearing from participants, so rather than us answering all the questions, if you've had any experience of why is it that the health sector does not manage to get a larger share of tax revenue? And if anyone would like to chip in and comment on that, Abiodun is indicating that he could provide some more information on the Nigerian experience. So I'm going to ask Abiodun to unmute his mic and please contribute. Thank you.
Thank you very much. It's been an interesting discussion, and the evidence that have been provided, are very useful and very similar in Nigeria. And based on some of the things you mentioned earlier, I do agree that some of them reflect what is currently happening in the country. But from my experience in the space in the last few years, some points clearly come out in engaging the informal sector. Usually, it's a very challenging sector to engage because of the unpredictable source of income, of the nature of getting a common and a common group among the informal sector. So that has been a major challenge. And so the transition at the moment in Nigeria is from a centralized national health insurance scheme to a decentralized health insurance scheme at the state level, such that you have state-supported health insurance schemes that engage both the formal sector and the informal sector. The benchmark really for this has been the newly passed and signed National Health Act, which proposes that the government puts adequate funding into primary health care and to the health insurance scheme. So the key point in our experience is that for Nigeria, public financing is the key to achieving universal health coverage, and it is really important not just in engaging the formal sector, but also in getting people from the informal sector, which is a majority of the population, also covered under health insurance schemes.
Thanks very much, Abiodun. Okay, so you were picking up then the issue of insurance schemes rather than how to draw the informal sector into paying tax, but I agree that it's relevant in terms of moving towards universal coverage. And I just want to pick up on one of the issues that was raised. Emma Wagner raised the question of did you look at tax evasion through the use of foreign tax havens? And Doris and Jane can add to this, but essentially no, we didn't look at that issue in this particular study, but it's very clearly other recent research has shown that in African countries, tax revenue could be dramatically increased if multinational companies paid the taxes that they should be paying in the African countries. So there is considerable tax evasion, and it makes economic sense for those companies, because corporate tax rates in some European countries are substantially lower than in African countries. So they would prefer to pay corporate taxes in European countries, but it's to the detriment of African governments. And so this is very much an issue, and Jane raised it, that this was one of the things that some of the interviewees raised was, yes, we have been able to increase tax revenue through greater compliance, basically of our domestic, of our citizens in paying taxes. But within the context of a globalizing world and things like e-commerce, it's getting more and more difficult to actually ensure compliance, particularly of individuals, high net worth individuals who take their funds offshore, but also large multinational corporations who are to some extent engaged in tax evasion. So I'm not too sure if Jane or Doris would like to comment on that. But also there's another question: did the conclusions of your study reinforce any previous work, including in the area of fiscal space? So I'm wondering, Jane or Doris, if you'd like to comment on either of those.
All right, I'll go first then. On the issue of tax havens, clearly the Treasury interviewers we talked to identified the challenges of that sort of thing. So for them, it's high on their agenda to try to solve these problems brought up by the international normability of finance. The problem, they can go so far in policing the system, but I think something I didn't put down as a recommendation. I don't think we had got that far in our thoughts. But the problem with governments trying to improve the system is that part of the problem is an international problem, not a local one. And so maybe a recommendation to add to our work would be that our own governments have to be active in the debates internationally about how to improve the international tax system. And there does seem to be some impetus behind efforts to improve it. Following the Sustainable Development Goals process, there have been meetings talking about this. So I think the climate is improving for that sort of regulation.
Great. And Jane and Doris, in terms of the conclusions of this study, did it reinforce any previous work that had been undertaken? So were the things that we found about how governments, how tax authorities managed to increase tax revenue without increasing tax rates, did it resonate with other studies? Was there any and there's also a question from Brendan. Are there mechanisms you could suggest based on the research in these countries through which more additional tax records resources could be used more for the health sector? So I think, Jane, you put forward some proposals, but it seems to be a really, really big issue. Is there evidence from other countries, I would say? Are there any other ideas of how the health sector can push for a greater share of increasing tax revenue?
So the issue of whether this reinforced previous work, looking at the tax system in this kind of detail was new for me in many ways. One of the things that was really interesting for me was how the tax collection agencies transformed themselves in all three countries. So not that I'd done any work on that before, but the changes were very striking in comparison to the problems we've had in the health sector with bureaucracies and bureaucratic problems with delegations, all those sorts of things. So I think what was exciting for me there was that the example of the tax collection agency could be applied maybe to new institutions in the health sector like national health insurance funds, because there clearly is a way to, within the public sector, create a highly motivated, efficient organization that can work towards equity. So that was not something that reinforced what I knew before, but gave me some new ideas. I think looking at the decline in the share of the total government budget enjoyed by health, that was certainly in South Africa. We had been analysing that for years, not always understanding why it was happening, but we had critiqued the government's macroeconomic policy that came out in 1996 called GEAR, and in a way a lot of the critiques in those times were predicting this kind of pattern, and so I suppose it has reinforced our predictions of that period. But I think that what was new in the research here was understanding the thinking of Treasury especially. It's not just that they are wedded only to a certain model of economic growth, but also they're very concerned about financial, how do I put it, the financial coherence and sustainability of the system, about the waste of money, about the difficulty of measuring output. So I think it both reinforced and in my mind introduced some new ideas about how to deal with Treasury. If one can understand that they have got really valid concerns about I suppose the fiduciary aspects of using money. I don't in fact know enough about other countries and how they've managed this issue. I think you had done some work for Chatham House, Di, that looked at this fiscal space.
Yes, I mean the work that we did for Chatham House was trying to pick up quite a bit on the issues of the need for global action in addressing some of the issues around reduced tax revenue in low and middle income countries due to tax evasion, tax havens, that sort of thing, and multinational companies' practice. But I wondered if I could just ask, I see Cara is online, Cara, whether you are able to comment on this issue of that Jane was raising, that when one starts engaging with treasuries, with ministries of finance, you suddenly start understanding what it is that they want from the health sector before they will actually increase budget allocations to the health sector. So I'm not too sure if you are hearing me, Cara. If you are, if you could unmute your mic so that I know that you will respond. Thank you.
Hi, Di. It's Cara here. So I've been long fascinated by this issue about how ministries of health interact with ministries of finance, because it almost, sometimes I feel it's a bit like that book, that ministries of finance are from Venus and ministries of health are from Mars. They have really quite different languages, and they have really very objectives. And I think that ministries of health really need to understand what it is that ministries of finance are looking for. And they, and when we have started to talk in a very preliminary way to ministries of finance, they are very concerned with budget execution, for example. So they're very likely to say, well, why should we give you more money? You haven't actually been able to spend the money that we allocated to you last year. They're also very concerned with efficiency, but I'm not sure that they have the right constructs to describe what we mean by efficiency and what is an efficient use of health, of resources for health. So I think there's enormous scope for more communication between health ministries and finance ministries, and for health ministries to get much smarter, to be able to figure out what is the language that ministries of finance want to hear, what are the buttons to push, what are the concepts they would like to explore. What is it that they want from the health sector in order to justify and support increased health spending?
I just want to add that since we undertook this study, which was almost the first one that looked at the comprehensiveness of tax reforms, we have been sharing the results, and as you probably, some of you understand, Kenya is implementing a decentralized system of government. And because of this capacity we've been undertaking, this has been, it's actually being funded by USAID, capacity building of the ministries of health at the counties level, which is the decentralized system of government. And since the program began, we've seen an increase in funding for health, and most of the counties are actually allocating up to 22% of the total county budget to health, which actually defeats what the national level used to allocate. We stood up at 7.6% by 2013. So we are seeing a difference in terms of how ministry is justifying the case, and also how they go about budgeting, undertaking the actual budget, and also seeking evidence that is crucial in terms of supporting the budget or the requirement that we've always missed in terms of, well, it is long-term. The health outcomes are long-term, so it is difficult to argue the case. But now they're becoming much smarter, and I think with increased capacity building, I think we can see changes, and of course also improved communication between ministries of finance and Ministry of Health in Kenya.
Great. So I just wanted to say thank you to everyone for joining. For me, the really strong messages that came out of this RESIST research was we shouldn't sit back and accept the statement that, sorry, there's no fiscal space. It's not possible to increase government revenue or government expenditure. We see in many African countries that government revenue is quite a small percentage of GDP. So potentially it is possible to actually increase. We should be looking at trying to generate more revenue. And these studies have shown that it is practically feasible, particularly through improving tax collection, through improving the capacity of the tax authorities, and improving compliance. So without even introducing new taxes or raising tax rates, it is possible to quite substantially increase tax revenue. But as the ministries or as people in the health sector, we shouldn't sit back and think that that is going to mean that it's going to translate into more resources for the health sector. We actually have to fight very hard to get additional funds, public funds, for the health sector. Very often other sectors are much more successful than the health sector is in getting a good share of public resources. And we need to engage with ministries of finance and understand what it is, what their expectations are. And my strong sense is that we need to actually develop greater health economics capacity within health ministries to be able to gather the kinds of evidence that will persuade ministries of finance that we are using resources effectively, that it makes a difference, the additional funds actually make a difference, are being well used, and that additional, even more funding would contribute to improving not only the health of citizens, but also contribute to economic development, reducing poverty, etc. So on that note, I'd like to just conclude the webinar and just thank everyone for participating. Thank you very much to Jane for doing such a clear presentation. Thank you to Doris for joining us, and any questions that you still have, we can answer via the blog or chat on the Resist website. Thank you very much to everyone.